Applying the guidelines to older adults, and I use this graphic because we're trying to stick a square peg in a round hole. Older adults, especially frail, those in long-term care, are not the people described, generally speaking, in the guidelines. So one example, I have an excerpt here from the Jerry RxFiles, which I hadn't mentioned previously. It's another book produced by RxFiles specific to older adults and optimizing treatment in this population, which we'll also throw into the draw, so don't forget to send your name in to Cheryl. But what you see in this particular table is on that left-hand column, your population. Are you over 80, under 80? Do you have diabetes? Do you have chronic kidney disease? And then within that, we get to see what the Canadians, the Americans, and the Europeans all think about blood pressure. As you can see, there's a bit of discrepancy. So what we know is that the optimal target for blood pressure really still remains in question. But what we've highlighted in the dark gray and the yellow text, if you can see that, is the threshold to treat is probably around 160 over 100. So if I have someone who's not treated, that's when I get worried about it in an older adult. And then I'm probably aiming for 140 to 150 over 80 over 90. But there's a lot of considerations, and we definitely need to individualize our treatment depending on if someone's frail, if they have comorbid conditions which may demand a bit of a lower blood pressure, how well they tolerate the medications that we use to decrease their blood pressure, and as well any adverse effects that may occur with those medications. So here's a very busy diagram of blood pressure in older adults. And the one thing we're going to highlight with that arrow is you see, it's hard to see, I know, but the bottom two triangles, one is the age group of 70 to 80, and the other is individuals over 80. And on the bottom left, you see your diastolic curve, and the bottom right, you see your systolic curve with a line running through it. And anything above that line is harm. That's your hazard ratio cutoff. So what you see, and again, might be a bit tiny on your screen, is diastolic right at the bottom there. It's hovering around 80. So for older adults, a little bit less than 80, all the way up to 90. When we get to the systolics, 140 is kind of on the line. So what this is telling me is that treating to a blood pressure target that is too aggressive, so either lowering too quickly or too much, can result in undesired effects. And we know this from hypertensive urgency situations, where we recommend a more conservative blood pressure lowering. So when someone comes in, they've got those super high numbers, we don't want to lower it in an hour, we want to lower it in a few days. Because what this does is it reduces the risk of potential adverse effects, such as perfusion complications, which can worsen the incidence of heart attack, stroke, and death, right? We don't want to be too cowboyish and attack that blood pressure too quickly, slow and steady. And we know when we do it too fast, those risks can occur. However, with heart failure, a lower blood pressure, if asymptomatic, so we're not dizzy, might be necessary to achieve those target doses of those medications that we know offer a mortality benefit. So it's certainly not black and white, and it's a bit of a challenge. But I think this is sort of your take-home message when it comes to blood pressure, is that harms of sustained too high blood pressure are seen when we hit that systolic of over 160, and again, sustained. We know our blood pressure can fluctuate over the course of a day, and we've probably all encountered that patient who takes their blood pressure 8 times a day and brings you that nice list. But on the flip side of things, because we often, I find, focus on that top number, don't forget about that bottom number, the diastolic readings, because there are harms of too low of a blood pressure as well, especially in someone with existing cardiovascular disease. So if that bottom number is less than 60 millimeters mercury, we can see an increased risk of stroke and again, cardiovascular disease risk. And if it's as low as 70 over 75, which isn't that low, there's an increased risk of mortality. So again, we see that J curve existing for mortality with both too high or too low of blood pressure. So we want to ensure we're not treating too much, we're not treating too little, but we're treating just right. It's our little Goldilocks principle when it comes to approaching blood pressure. But if you're wondering if you're over-treating blood pressure, ask the question of that person in front of you, are you dizzy? Are you unsteady or are you falling? And then if the answer is yes, definitely reassess those blood pressure medications as well as your blood pressure target. It won't always be blood pressure, but it's certainly something you should be evaluating. And remember that guideline targets, generally the consensus is when you're over 80, it's okay to back off to that 150/90. But again, we certainly need to individualize that target and balance the risk of medications, their adverse events, the risk of too high or too low blood pressure versus the benefit, right? What are we trying to achieve at the end of the day? So remember to let that target serve your patient and not the patient serve that target. Don't be chasing an unattainable blood pressure target. You'll probably just result in falls and more harm to the patient. So I'll turn it back over to Dr. Martens about blood pressure targets.
Well, as Julia said, there's lots of different guidelines out there. If you don't like the one you're looking at, just look around. You'll find something that agrees with whatever your preconceived ideas are. So no problem. The question that I do ask the seniors is, do you feel dizzy when you get up? Amazingly, many times the answer is yes. When you dig a bit further, you find out there is a bit of postural hypotension. I ask them if they're tired a lot, and if there's a lot of hints of problems, then maybe we should be backing off, okay? I am worried about them getting up and falling over in the middle of the night. That is not going to help anybody, and especially if they're a little bit sick, a little bit of diarrhea, it's going to be much more likely that's going to happen. Assessing blood pressure is also rather difficult. Yeah, I know you put a cuff on and you measure it, not that hard. But trying to find out exactly what it is can be difficult because a little bit of stress makes it go up, a little bit of anxiety about something, they rushed into the office, they had trouble finding a parking spot, all kinds of things will push the number up. I do utilize a BP True monitor. It takes the pressure 6 times in a row, averages out the last 5, and it's always interesting to me how often the number is so much lower than what I was getting when I took it myself. And I tend to rely on those numbers an awful lot. Occasionally do use 24-hour ambulatory blood pressure monitoring. I've got a few concerns about that one because I've seen people who had the cuff on and when they're wincing in pain every time that thing blows up, it's probably not an accurate number, okay? So the BP monitor at the office, I do use a fair bit, and maybe check it over a few weeks to see what it's doing, you know, unless it's 210 on 120. But most times, we're not in a crisis situation. Let's try to see where we're going and also avoid harm. So if lowering the blood pressure to guideline levels puts them at risk, in my opinion, it's not worth it. There is increased risk with higher blood pressure. And many seniors, their diastolic continues to drop as they get older and their systolic goes up. How much of that is actually true? How much of it is Osler's phenomenon and so forth? I don't know, okay? But measuring it is actually sometimes a lot trickier than it sounds. So, in other words, the older I get, the harder it is to do some of those things.
I often get the, because I work in the community drugstore, the individual who marches to the back of the store, plops himself down, sticks their arm in, and gets the reading, and it's higher than they thought, and they're very anxious and they come see us. And I think it's always a good reminder about how to take a proper blood pressure reading. Rest 5 minutes before, ensure your arm is resting, you're not holding it up at about heart level, no talking, feet flat on the floor. Ideally, you don't have to go to the bathroom, and you didn't just have a smoke and a coffee. Yep. All things to ensure we're getting good, accurate readings. I always make them go back and do it again, and it magically comes down, as you say, after 2 or 3 readings.
Many patients want to talk to you as you're doing the blood pressure, which is nice, but it raises your blood pressure. So if you tell them to shut up, that raises their blood pressure too. So I'm not sure what to do.
Leave the room. Well, in terms of blood pressure, let's go back to our case. Again, we have our 82-year-old female. So she's on hydrochlorothiazide 25 milligrams a day. She's on the Ramipril 10 milligrams a day. We took her blood pressure, and when we averaged it out using a wonderful BP True machine, it was about 127/72. We know she has type 2 diabetes, and we know she has urinary incontinence. So I wonder what's jumping into your mind right now. Maybe what's the first thing that comes to mind? When I look at it, and my older adults, I think, that's probably lower than it needs to be. certainly would inquire about symptoms. But something else I'm wondering about is, okay, it's already pretty low, and she has urinary incontinence, and she's taking a medication that makes her want to pee, a diuretic, hydrochlorothiazide. I think a good approach in this particular individual would be to stop the hydrochlorothiazide, doesn't require tapering, and then reassess that blood pressure later on and see if it did increase beyond a point that we would assume is acceptable for her, and perhaps we'd have to restart, as well as reassess those urinary incontinence symptoms, because maybe that oxybutynin, again, can be decreased if not discontinued. If you were going to approach the ramipril or the Altase and adjust that dose, just a reminder to always reassess potassium and kidney function whenever adjusting the dose of medications in this ACE or ARB class, as they certainly can affect those, and we know how potassium is quite important to monitor and is a fine window of when we can get into trouble. So I promised you earlier a little information about anticholinergics. So this is how I remember the side effects of an anticholinergic. And bear with me, these medications don't actually physically do this, but it's my little way of remembering. Anticholinergics dry things out. If I have a dry bladder, I'm going to have urinary retention. If I have a dry bowel, I'm going to have constipation. If I have a dry mouth, obviously I have a dry mouth. But what would happen if I were to dry out my brain? My memory probably wouldn't work that well, and the further I dried it, the worse my memory impairment may become, and in a worst case scenario, I may become delirious. And that's exactly what anticholinergic medications can do, and that's probably our primary concern in older adults, is that cognitive effect. So here you see a list of side effects: dry mouth, blurred vision, constipation, drowsiness, sedation, hallucinations, memory impairment, difficulty going to the bathroom. Think of your men as well with enlarged prostates, confusion, delirium, decreased sweating, and decreased saliva, tied into that dry mouth. But all these side effects can certainly add up and cause a lot of quality of life issues for older adults. And the challenge with anticholinergics is when you combine 2 or more anticholinergics, they don't really add up, they sort of go exponentially, so the effects become rather pronounced. So how do you know which medication is anticholinergic? Well, there's probably over 600 medications with anticholinergic properties, so it makes it a tough list to remember. But on the slide here, you'll see a resource from RxFiles entitled Anticholinergics, reference list, of course. And something that should jump out at you is that there's red and blue. And I know you probably can't read all those words, but note the red and blue, because if it's red, it's stop, reevaluate. This is a very anticholinergic medication. Is there an alternative, or can we get rid of it? In the blues, it's not that anticholinergic, but when we start to add blues, again, they become exponential in terms of their effects. So we certainly want to minimize our blues. So a few that I wanted to point out that, again, I'm sure are a challenge to read from where you are in the audience, is a red medication under antidepressants. You'll find paroxetine is the only SSRI or antidepressant that's red in that family. So often we try to lower the dose or switch to something like sertraline or citalopram. You'll see Gravol is red. Gravol is a great medication for nausea. It's quite effective and very inexpensive. But the problem is when you have someone who already has cognitive impairment or dementia, it can worsen that cognitive impairment. And even more concerning is if you have someone with behavioral challenges, it can actually trigger or worsen behaviors. And people are familiar with the side effect of Gravol, where it can cause drowsiness, and folks will use it to help them sleep. And there is a related medication, Benadryl or the diphenhydramine, which is marketed as a sleeping medication. But they can dry you out, and in older adults, this risk can become certainly a problem. And if you are using a medication like Gravol to help you sleep, the sedative effects will probably dissipate after 3 to 4 days anyway, and you're just left with the adverse effects. So caution with that one. But if you're using it for nausea, low dose as needed, certainly appropriate. If we look to the antipsychotics, and our atypical ones, our newer ones that are out there, you'll note quetiapine is red, risperidone is blue. And often we see risperidone better tolerated than quetiapine in the studies, although neither are very well tolerated. And then you'll see oxybutynin, red. All our antimuscarinics, all those medications intended to help with urinary incontinence are likely anticholinergic. There's a new one we're not 100% sure about, but because these medications are meant to help support urinary retention, if you will, or dry up that bladder, you will see they will have cognitive effects. And that's a hard trade-off for a patient to consider, your continence versus your cognition. And that's a good discussion to have with an individual and decide what might be best for them. So back to the case here. We have that metformin, ASA, atorvastatin, sertraline, colace, oxybutynin, amitriptyline, hydrochlorothiazide, ramipril, and zopiclone. You've got those all memorized, I'm sure. So we've got this individual before us saying, my memory is just not as good as it used to be. It could be potentially signs of early cognitive impairment, but it could also be medication induced. And one question I have beyond, does she need the oxybutynin, and hopefully we've resolved that problem when we got rid of the hydrochlorothiazide, was why is she taking amitriptyline, a tricyclic antidepressant known to be anticholinergic and known to be the more anticholinergic compared to others, such as nortriptyline, which is less anticholinergic. She didn't have a true indication for this. Maybe it was for sleep, I'm not exactly sure, but that would certainly be a medication that I'd be exploring with this particular individual to determine if she still needed it, and if discontinued would improve her memory symptoms. So moving on to one last concept before we go to a break is shared decision making. So what is shared decision making? It's a respect for a patient's values, preferences, and expressed needs. We need to provide clear, high-quality information and educate both our patient and their families or caregivers. It involves, at minimum, a clinician, so any healthcare professional and the patient, where both parties share information. It's give and take. So the clinician offers opinions, describes the risks and benefits of the various treatment options, and sometimes it's not always a medication. And the patient expresses his or her preferences and values. So it's really about asking what matters to you as well as what is the matter. So sometimes it's not really clear what the right thing to do for a patient is, because we have poor evidence or no evidence, and we're faced with this crossroad of medical options, right? Do we do something or do we do nothing? And some examples of this might be statin for everyday primary prevention, so you've not had a heart attack. Is a statin right for you or not? Or maybe something a bit more complex, like genetic and cancer screenings and tests. Well, you may have the genes. Does it mean it's going to express itself and you'll actually experience cancer? So those are those situations in which it's very gray and we're not sure what's always right or wrong, and we have to individualize our treatments. So I'll pass it back to Dr. Martens to address that challenge.
Well, shared decision making, definitely, that's an area that I've been very much getting into over the last 10 years. It's called other things in other places. I've heard it described as minimally disruptive medicine and various other things as well. And as Julia says, it's based on what's important to the patient values, and talking about the risk and benefit. Those questions about statins for primary prevention, well, you can do some calculations and tell them roughly what their risk is and ask them if they want to take a pill for this. Many times the answer is no. You have to present both sides, the pros and the cons, and that's something that's a little bit awkward in some of the fields that we're in. I had a patient a while ago who has atrial fibrillation. I went over, calculated his CHAD score. From that you can tell roughly what his risk of having a stroke in the next year is, which is actually fairly high, often like 8–10% in a year, okay? And then the benefit that you get from warfarin in taking this. This was before the NOACs came out. And went over it, spent a bunch of time, and I asked him, are you interested in taking this? Warfarin. That's rat poison. No, I'm not taking that. You know what? It's their choice. And it doesn't matter if you have a specialist who's telling you, you've got to get that person on this pill. It is their choice ultimately. And if you browbeat them into taking a pill that they don't want to take, they're not going to take it. They're going to take your prescription and walk out the door. So you need to get buy-in. They need to agree that this is something that is important, because sometimes their values, their perception of what is important is different than yours. I've been to 2 conferences where the CMPA, the group that does malpractice for physicians, has talked about this whole thing. And they have said very clearly that guidelines are not the same as standard of care. If the patient in the discussion with the doctor says we're not going to do what the guidelines say, that's okay, but make sure you document it. And for all the primary care physicians, nurse practitioners, and so forth, that's an important concept. You got to make sure that you document the discussion.